Good afternoon, everybody. And at the outset, I'd like to thank Dr. Mayuri Kamar for giving me this opportunity to be a part of her IC. And I'm going to take you through the role of anterior segment imaging in pseudophakic glaucoma. So pseudophakia does not cause ocular hypertension by itself, but Radius et al. Said that cataract extraction and IOL implantation do not cause a statistically significant increase in IOP. Secondary glaucoma in pseudophakia immediately after surgery or weeks to months later could be open angle, closed angle, or acute or chronic. So the early IOP rise can actually occur in all these conditions that you have here: malignant glaucoma, pupillary blocks, AC IOLs, iris-supported lenses, iridocapsular lenses, inflammatory reaction, loose cortical matter, obstruction of the outflow channels, loose cortical matter, the OVDs that we use, and of course post-operative steroids. And the late intraocular rise of pressure can occur in the uveitis glaucoma hyphaema syndrome, prolonged outflow obstruction, traumatic scarring, inflammatory reactions, iris vitreous incarceration, synechiae formation following that, presence of vitreous in the anterior chamber, secondary glaucoma, pigment dispersion, or host cell glaucoma. So the anterior segment OCT, it's a non-contact rapid imaging device. My speakers' predecessors have actually done my work for all this, so I wouldn't go into the basic principles and all that. I'll just tell you the advantages: semi-automated, not operator dependent, and has good reproducibility. Disadvantages, however, are lesser depth of penetration due to shorter wavelength of the light source. Ultrasound biomicroscopy, again, this has been spoken about by Dr. Mega very well. So I'll just again say the advantages: better to visualize posterior chamber structures like zonule ciliary body and anterior choroid, useful for evaluation under anesthesia, and disadvantages: poor intra-observer reproducibility. So again, the anterior segment OCT versus the ultrasound biomicroscopy. I don't think I'll go into this because you have heard all this from the previous speakers. I'll come straight to malignant glaucoma. Similar findings with ASOCT and the UBM: iridocorneal touch, anterior displacement of the iris root, appositional angle closure. OCT better resolution but limited visualization of the lens, ciliary body and anterior vitreous. Imaging of the anterior rotation of the ciliary body not possible, and UBM may not be convenient in the immediate post-operative period. So if you have a look at that there, the UBM, the anterior displacement of the iris root that you see out there, and the uniformly shallow anterior chamber, and after a pars plana vitrectomy, this is what you could see. And IOL-induced pupillary block, that's less frequent, but aqueous outflow through the pupil is blocked by various mechanisms. Could be anterior chamber IOL, where pupil occlusion is by lens optic, peripheral iridectomy in all cases works well. Then posterior chamber IOL, post-operative inflammation, aqueous accumulation between posterior capsule and anterior vitreous face, IOL in the sulcus, which actually alters the anatomy there, and incorrect inversed IOL implantation. That is, of course, a wrong opposition and less common with modern phakic IOLs. So may occur in the immediate post-operative period or even years later. The risk is higher in diabetic patients and in glaucoma patients who have already angle closure. So if you look at the UBM there, the PCIL apposition that you see with the iris out there, easily visible. And again, the UBM or ASOCT would show you the high vault in a phakic IOL. Uveitis glaucoma hyphaema syndrome, or the Ellingson syndrome, that's intraocular caffing due to IOL. So UBM is used to visualize the malposition of the IOL haptics and contact with the uveal tissue, as you see out here, and you can see it here also clearly. So post-operative inflammation, obstruction of trabecular meshwork by inflammatory cells, fibrinoid erythrocytes. The risk factors: excess manipulation, retained lens matter, preoperative or uveitis, and may lead to peripheral anterior synechiae and pupillary block. OVDs in the anterior chamber, we do use a lot of high molecular weight OVDs nowadays. So reduction in aqueous outflow due to the trabecular meshwork blockage, and transient peaks are generally there between 4 to 7 hours post-operatively, which again returns to baseline within several days. And sodium hyaluronate definitely has a higher risk than your HPMC. So peripheral anterior synechiae, chronic angle closure, risk factors are flat anterior chamber, wound leg, or inflammation, as you would see that in the ASOCT that you see out here. So vitreous in the anterior chamber, which can cause pupillary blocking of the angle and preventing drainage. So that could be very clearly seen in the UBM, pupillary block caused by vitreous in the anterior chamber. Pigment dispersion, transient rise in IOP, open angles. Risk factors are IOL in the sulcus or an AC IOL. So gonioscopy would show you heavy pigmentation of the trabecular meshwork. The UVM would actually show you a concavity in the iris and increased iridozenular contact. So in summary, surgical intervention may lead to glaucoma. Careful instrumentation during surgery is very important. Care for pre-existing glaucoma, intra and post-operatively is mandatory. Adequate post-operative steroids, keeping in mind steroid-induced intraocular pressure rise, and judicious use of anterior segment imaging in the diagnosis and monitoring of response to treatment in these eyes. Thank you.